Hello, good morning. My name is Tiziano Barbui. I'm from Bergamo in Italy, Foundation for the Clinical Research in the Bergamo Hospital. My interview today will deal with thrombotic events in MPN. Particularly, I will face a problem that is related to primary prophylaxis that is intended to avoid the first arterial or venous event. You know that classic Philadelphia negative MPN, including polycythemia vera, essential thrombocythemia, and myelofibrosis, are characterized by uncontrolled clonal proliferation of multipotent bone marrow progenitors. And this is sustained by acquired mutation in JAK2, CALR, and MPL genes. The expansion of the mutated clone triggers an inflammatory response. And this influences the development of associated vascular complications, disease progression into myelofibrosis and acute leukemia. We have now novel insights into the pathogenesis of MPN associated with arterial and venous thrombosis, including a complex interplay among blood cells, endothelium, and the hemostatic system. Despite progress in diagnosis, prognosis, and therapy, vascular events remain a major unmet clinical need in these diseases. In this interview, I would like to make some points in order to update the last knowledges on primary thrombotic prophylaxis. The first point is that arterial and venous thrombosis in MPN occurs in 20% of cases in PV, ET, and PMF before the phenotype, before diagnosis. This finding is generating great interest on the possible inflammatory pathogenesis that could operate even before the characteristic phenotype of PV, ET, or PMF. And this could be supported by the presence of clonal hematopoiesis also years before the appearance of the phenotype. And the risk of thrombosis persists even after diagnosis, especially in the first years, and then remains stable over time. To avoid this vascular complication, primary prophylaxis is important and should be considered in two groups of patients, in low risk and high risk patients. High risk, of course, is for thrombosis. In PV, especially, you have to control hematocrit. This is very important because hematocrit should be kept stably less than 45%. This was demonstrated by the CYTO-PV randomized clinical trial. However, in clinical practice, it has been calculated that phlebotomy therapy alone may be not sufficient. Normally, after reaching the target hematocrit value with close bloodletting, patients are seen every 3 months, usually in clinical practice. And with this policy, it was noted that only 30%, 30 to 40% are able to keep steadily hematocrit less than 45%. So in the great majority, patients with a PV treated with a phlebotomy only are able to keep the hematocrit on target. In low-risk patients, you know, phlebotomy and aspirin are the only procedures for treatment. And phlebotomy may be then, in low-risk patients, not adequate to reduce the incidence of both venous or arterial thrombosis, despite the use of aspirin. Few months ago, the European Leukemia Net updated the PV treatment guidelines and established that there are subgroups of low-risk patients in which to propose cytoreductive therapy, even if they belong to low risk. But we cannot use hydroxyurea here because there is the tendency to transform in these patients due to hydroxyurea in some patients. So it's not indicated by any guidelines. Today, however, we have a new drug, a pegylated interferon, and the raw PEG interferon is now available. Is available in Europe because it has been approved by EMA. It's available also in United States. It has been approved by FDA. And in some patients with low risk it can be employed. For example, in young women willing to become pregnant, this could be the drug that could be used safely. A new interest is now, there is a novelty that concern a drug that is currently in phase 3 experimental studies. This is a mimetic of hepcidin. Hepcidin is a drug that regulates the availability of iron in the bone marrow. And this drug significantly was able to reduce the need of a phlebotomy. However, I have to say that at the moment, we don't have any data indicating that this corresponds also to a reduction of thrombosis. Concerning low-dose aspirin, you know that low-dose aspirin is currently used 100 milligrams a day or less, administered once a day, in the morning, in the evening. And the IPSET thrombosis scoring system has helped a lot to recognize patients who deserve this treatment with aspirin alone, and who are patients who should not be treated with aspirin because they are a very low risk of thrombosis. So aspirin is totally indicated in JAK2 positive patients with the ET, but not in all patients not harboring JAK2 mutation is indicated. So the novelty now concerning aspirin is about the dosing of this drug. In thrombocythemia, you know, there is a rapid turnover of platelets, and this is characteristic of thrombocythemia, particularly thrombocythemia, but it could be applied also in polycythemia vera, at least in some patients. Now, investigators addressed the question whether one aspirin a day may be sufficient to abolish the thromboxane generated by platelets. You know that the thromboxane has a prothrombotic action. A very recent study has shown that 2 low-dose aspirins a day are needed to obtain an optimal result. In this way, you abolish completely the production of thromboxane by platelets. This is not the case after a single aspirin a day, because the rapid turnover of platelets. It will be interesting to see if this can reduce the incidence of thrombosis in both primary and secondary prophylaxis after an arterial or venous event. So these are the novelties in low-risk patients in terms of prevention of the first episode of thrombosis after diagnosis that regards arterial and venous thrombosis. Concerning patients at high risk of thrombosis, according the commonly accepted definition, hydroxyurea is the standard of treatment. For instance, in essential thrombocythemia, hydroxyurea is demonstrated to reduce the incidence of the first episode of thrombosis in a patient as compared to placebo or anagrelide. The drug is recommended then also in a condition of extreme thrombocytosis. Concerning extreme thrombocytosis, I mean platelets values over 1.2 or 2 million, there is a paradox. These values are not associated with thrombosis. These values are associated with a bleeding tendency. And very recently, again, European Leukemia Net produced some indication. Many of these patients harbored the calreticulin mutation. And in some of them, especially for extreme thrombocytosis, treatment could be indicated. It's clear that if a patient is a young patient, interferon is more indicated versus hydroxyurea. Ruxolitinib is the second drug that is very used to avoid the occurrence of thrombosis, especially in PV, is registered, reimbursed in PV resistant or intolerant to hydroxyurea. And this has shown to obtain hematological responses and is now recommended by international guidelines. However, I have to say that it is not yet known whether it can reduce thrombosis. We did a meta-analysis, I have to say, looking at all the studies produced so far dealing with ruxolitinib, both experimental or observational studies, and there is only a trend over hydroxyurea in favor of ruxolitinib, but there is not yet a clear demonstration because we don't have clinical trials having as a primary endpoint the reduction of thrombosis. The third drug that is available is ROPEG interferon in high-risk patients with PV, and in some, as I alluded to before, some patients at low risk, but with high risk characteristics. So this drug has shown to be effective in both high and low risk, and particularly indicated the younger patients, younger, less than 60 years. The drug is ROPEG, as I said, is reimbursed now in many European countries. And it should be noted that in low-risk patients, this drug has shown clear advantages over standard therapy in a randomized clinical phase 2 studies, of which we produce the first interim analysis, and the data are available in the Lancet Hematology. So, in conclusion, the question I would like to face in this interview was about whether in PV and ET, which are the best way to avoid the first episode of thrombosis, meaning that which is the value of phlebotomy, aspirin, new drugs to avoid the first episode, both of arterial and venous thrombosis. So we have aspirin, we have phlebotomy, cytoreductive therapy, but in spite of that, we still have thrombosis that remains elevated both in ET patients, but also in PV patients, but also in myelofibrosis as well. This estimates about 2 to 5% are extremely elevated still now. So that we require to explore new therapeutic targets. And as I said before, at the beginning of this interview, the mutation can cause an inflammatory status in these patients. And inflammation has a big role on the pathogenesis of thrombosis. So inflammation could be the target of new drugs now. Some of the drugs we are using today, for instance, ruxolitinib, has also an anti-inflammatory activity, but also for interferon. Less evident is the anti-inflammatory activity for hydroxyurea. At ASH 2021, last December, biomarkers of inflammation, such as neutrophils to lymphocytes ratio, were found associated with the JAK2 allele burden, higher than 50%. And importantly, these indicators were elevated, particularly in the prediction of venous thrombosis, not arterial thrombosis, venous thrombosis. This finding was applied also in a score system in ET, and also in this disease, the neutrophil lymphocyte ratio was associated with the venous events. So it means that inflammation status operates very much in the cause, or is associated, better to say, with venous thrombosis. Therefore, future programs of primary prophylaxis of thrombosis in MPN should consider separately arterial and venous thrombosis. In this latter, cellular inflammation markers seem pathogenetically more implicated. That's all. Thank you for listening to me.